Bismillahirrahmanirrahim. This is Dr. Nurshad and welcome to my today's topic, Intrahepatic cholestasis of pregnancy from Green Top Guideline 43. Now we will look at how we can diagnose ICP or intrahepatic cholestasis of pregnancy. According to the new guideline, if any woman who have itching in skin of normal appearance and raised peak random total bile acid concentration 19 micromole per liter or more, then we can consider the case as a ICP. So here we can see that the women have itching and the skin will be normal appearance. There will be no rash and the bile acid concentration is at least 19 micromole per liter. Then we can consider having ICP. In the UK, the incidence is 0.7% of pregnancies in multi-ethnic population. However, in Indian, Asian and Pakistani Asian origin, it is 1.2% to 1.5%. And ICP is a multifactorial disease. The onset symptom is common in the third trimester of pregnancy. However, rarely it can happen in the first and second trimester of pregnancy. In this slide, we can see terminology for pregnant women with itching of normal skin. We can see at first it is gestational pruritus. When there is itching and peak bile acid concentration less than 19 micromole per liter, then we can say it's a case of gestational pruritus, not an ICP. And if the bile acid concentration at least 19 micromole per liter, then we can consider the case as a ICP. And how we can classify ICP? Mild ICP, moderate ICP and severe ICP. In case of mild ICP, the bile acid concentration is 19 to 39 micromole per liter. Moderate ICP, we can say if the bile acid concentration 40 to 99 micromole per liter, and severe ICP when the bile acid concentration is at least 100 or more than 100 micromole per liter. In this slide, we can see how to diagnose a case of ICP. If any woman come with itching and raised bile acid concentration, we can consider this lady may have ICP. So we have to take a brief history and we have to carry out examination and some investigation to rule out other causes of itching and liver dysfunction. Because this ICP is a diagnosis of exclusion, we have to rule out some other causes that may cause this type of itching and abnormal liver function test, and offer repeat liver function test and bile acid measurement in women with normal bile acid results whose itching persists and no other cause is apparent. So we can repeat the test if we do not find any abnormality but her itching is persistent. And if resolution of itching is associated with normalization of bile acid and liver function test during pregnancy, then the diagnosis of ICP is unlikely to be correct. That means if any woman have abnormal liver function test but during her pregnancy it comes to normal, then it is unlikely to be a ICP. So the ICP, for the diagnosis of ICP, we need to have some criteria on his itching, and the skin appearance will be normal, and the bile acid concentration will be at least 19 micromole per liter or more. In this slide, we will see the role of other investigations of the ICP patients. According to this guideline, additional laboratory and imaging investigations are not recommended in every woman but could be considered on an individual basis. And we can consider the antenatal testing only if there are atypical clinical symptoms, presence of relevant comorbidities, or early onset of severe ICP. And consider postnatal investigations in women in whom resolution of abnormal liver function test is delayed or doesn't occur. So we also can consider some postnatal test if the liver function test doesn't come to normal or delayed to come to normal. In that case, we can do some additional test. Otherwise, it is not required to do any additional test in case of ICP. Here we will see the role of hepatologist in case of ICP. Discuss the case of ICP with a hepatologist if the women have severe or very early or atypical presentation, then we can consult with a hepatologist about the patient. Now we will see what are the maternal and perinatal risks. Advise women with ICP that their predominant symptoms will be itching and that can be severe and it may affect sleep. Women with ICP may have higher chance of developing preeclampsia or gestational diabetes, and they should have blood pressure monitoring and urine monitoring testing for gestational diabetes according to national guidance. So these women are high risk for developing gestational diabetes and preeclampsia, and they should have monitoring for this condition. This slide is showing the risk of stillbirth in a patient with ICP. In a woman with peak bile acid concentration 100 micromole per liter or more, the risk of stillbirth is higher than the background risk. And women with moderate or severe ICP, they have an increased chance of having meconium containing liquor. And that means if the women have moderate or severe ICP, we have to monitor the patient and the fetus with more vigilantly. How we can do pregnancy care and fetal monitoring of a patient with ICP? At first we can see that here according to guideline the ICP patient should be monitored in a concentrate late maternity unit. And in women with ICP, consider repeating liver function test and bile acid after 1 week and then determine frequency on an individual basis. That means after 1 week, we have to determine the frequency of test according to her symptoms and according to her laboratory findings, and it is individual basis. Clinicians should be aware that fetal ultrasound and cardiotocography do not predict or prevent stillbirth in ICP, and advise women with ICP to monitor fetal movement and present for immediate assessment at their local maternity unit if they have any concern. So, in case of ICP, there is no test that can prevent or predict stillbirth. So, the patient will be advised to monitor fetal movement, and she will attend local maternity unit if there is any concern of fetal movement. Now coming to treatment of ICP. There are no treatment that can improve pregnancy outcome, or any treatment have limited benefit. But we can consider some treatment that are symptomatic as like topical emollient such as aqueous cream with or without menthol that can improve skin symptoms. And consider antihistamine agent such as chlorpheniramine that can improve itching at night. And this treatment, the effectiveness of this treatment is uncertain in women with ICP. Do not routinely offer ursodeoxycholic acid for the purpose of reducing adverse perinatal outcome in women with ICP. And consider maternal vitamin K treatment only if there is appears to be reduced absorption of dietary fat. So if we see there are presence of steatorrhea, that means fatty stool, or evidence of abnormal prothrombin time, if coagulation studies are performed, then we can treat the patient with vitamin K supplement. Here we can see the delivery plan and management of a case of ICP. It depends on the severity of ICP. The delivery planned, consider planned birth at 38 to 39 weeks of gestation in women with moderate ICP with peak bile acid 40 to 99 micromole per liter and no other risk factor. So in case of moderate ICP, we can consider the birth at 38 to 39 weeks of gestation and advise them that the overall risk of stillbirth is similar to the background risk until 38 to 39 weeks of pregnancy. So after these 38 to 39 weeks of pregnancy, the risk of stillbirth is more. And consider planned birth at 35 to 36 weeks of gestation in women with severe ICP, where the bile acid concentration 100 micromole per liter or more. And we will advise them that the risk of stillbirth is higher than the background risk. And offer continuous electronic fetal monitoring to women with peak bile acid 100 micromole per liter or more. In case of severe ICP during labor, we can monitor the fetus with CTG. In the postnatal period, a patient with ICP will have resolution of itching and liver function test will come to normal, and this will confirm the diagnosis of ICP. According to this guideline, ICP itself doesn't influence their choice of contraception or hormonal replacement therapy. That means the woman with ICP can take any type of contraceptives. For women with ICP and previous cholestasis, secondary to combined hormonal contraception, that means estrogen containing contraception, advise them to use progesterone only or non-hormonal methods. So progesterone only or non-hormonal method is for women who have previous cholestasis secondary to combined hormonal contraception. Otherwise, the lady with ICP can take any form of contraceptives. In this slide, we can see the recommendations for future pregnancies. And here we can see there is an increased chance of recurrence of ICP in subsequent pregnancies. So, the patient with ICP need to perform a baseline liver function test and bile acid concentration in their booking blood investigations to rule out any recurrence of ICP in the next pregnancies. Thank you all.